Thank you very much, troublesome advocate. I just want to start by saying that this is my favourite meeting of the year, and I mean that. We go to lots of meetings, as Mary talked about, and, most of those meetings dehumanise this disease. And to stand up here in front of all of you and actually remind ourselves why we do this is what it's all about. So it's an incredible honour to be up here, and I'm very grateful to be talking in front of you all. I'm now for something completely different, because I'm going to be talking about AL amyloidosis, which we haven't heard a huge amount about today. I've been asked to keep it very simple, and I apologise. Never good to start a talk with an apology, but I apologise to those of you who essentially will know all of what I'm going to talk about. So, amyloidosis is a protein deposition in the tissues. Amyloid fibrils depositing in the tissues, okay? And we divide amyloid into either localized or systemic. In systemic amyloidosis, the particular protein that forms those amyloid fibrils, by definition, is circulating in the bloodstream. And so in systemic amyloidosis, that protein that is circulating in the bloodstream can misfold, form fibrils, and technically deposit in any tissue in the body. Okay? And we divide the different types of systemic amyloidosis by which protein it is that misfolds and forms the amyloid fibril. So we talk about ATTR, AL, A this, A that. All types of amyloids start with A. And the TTR is because it's the TTR protein that forms the fibril. In AL amyloidosis, it's a protein called a monoclonal immunoglobulin light chain, the L standing for light chain, that misfolds and form the amyloid. And in all the different types of amyloid, it's a different protein that misfolds, becomes a bit sticky, and deposits in the tissues. AL amyloidosis is a condition, it's essentially two diseases. Okay? In order to get AL amyloidosis, one needs to have a bone marrow condition and produce an excess of these light chains. And if you're producing an excess of a light chain which misfolds, that can deposit as amyloid in any tissue in the body. So that is AL amyloidosis. It's worth just mentioning, we've heard a lot about ATTR amyloidosis today, and it can often be very, very difficult to differentiate between AL amyloidosis and ATTR amyloidosis, which are the two commonest types of amyloid that we see. And I'll talk a little bit more about that. AL amyloidosis, like all types of amyloidosis, is more common as one gets older, and it's also slightly more common in males than females. Again, all types of amyloid seem to be more common in males than females. We don't understand why. One thing that's worth mentioning is that what we call a monoclonal gammopathy, so the bone marrow abnormality that leads to excess production of light chains, is incredibly common as one gets older. And in most patients, that monoclonal gammopathy doesn't lead to any disease. Okay, so the presence of a monoclonal gammopathy, which by definition underlies AL amyloidosis, plus amyloid in itself, is strongly suggestive that the patient has AL amyloidosis. They've got the underlying disease and they've got amyloid, but it doesn't prove it. And we have patients who have a monoclonal gammopathy, amyloid, and the amyloid turns out to be ATTR amyloidosis. And that's one of the big challenges for diagnosis, and that's one of the big challenges and the reason that some of you may have undergone a cardiac biopsy, because you've got a monoclonal gammopathy, you've got amyloid deposits in your heart, and the question is it AL amyloidosis or is it ATTR amyloidosis with an incidental monoclonal gammopathy that's not actually causing any disease and is unrelated to the amyloid? And the reason we need to differentiate between these different types of amyloid is they're treated completely differently. They behave differently and they're treated differently. So it's absolutely essential to prove what type of amyloid a patient has. And, you know, we've talked today about AL and ATTR, but there are 32 types of amyloid, actually. And at the Amyloidosis Center, we see many, many different types of amyloid. So it can be a real challenge to make the correct diagnosis, and that's particularly important because all these different types of amyloid, although they overlap, they're treated differently, they behave very differently. So in terms of AL amyloidosis, one still needs a biopsy from a particular tissue to show the presence of amyloid, and then one needs to confirm what type of amyloid one's dealing with. In ATTR amyloidosis, we've heard a lot about DPD scans, blood and urine tests. Most patients with ATTR amyloidosis, or I should say many patients with ATTR amyloidosis, no longer need a biopsy. And many of you will have been diagnosed without necessarily having a biopsy. Although, as we've heard this morning, many patients do still need a biopsy. But in AL amyloidosis, you still need a biopsy, and you need to confirm what type of amyloid is present in the tissues. In terms of the clinical features, the disease tends to affect the heart. So the first thing for me to say is it can affect pretty much any organ in the body. And no two patients with AL amyloidosis are the same. One patient might come in with heart failure, next patient might come in with kidney failure, next patient might come in with neuropathy, next patient might come in with carpal tunnel syndrome, next patient might come in with an enlarged tongue. It's a very, very variable disease. Next patient might come in with all of the above. So it's very heterogeneous. It's very different to ATTR amyloidosis, which, although, as we've heard this morning, does vary, it tends to behave in a similar fashion at least, whereas AL amyloidosis can behave very, very differently. The most common presentation is with disease in the heart, and you can see those numbers there. It slightly depends how you define disease in the heart as to what the actual, the prevalence is. But involvement of the heart is common, and involvement of the kidneys is common. And in fact, if patients may present with heart disease, but typically if they present with heart disease, they'll also have involvement of other organs. And this is sort of the dominant organ, if you like, in red, versus the other organs that are involved in patients with AL amyloidosis. And you can see the dominant organ most frequently is the kidneys, and then most frequently is the heart, but other organs are usually involved at the time of diagnosis. And it can be any of the combinations that I've talked about earlier. When patients present with kidney disease, they tend to have either, I'm a nephrologist, and from a kidney perspective, things are very simple. Patients present in two ways. They either have protein in the urine, or they get kidney impairment, which we can detect on a very simple blood test that people will have whenever they go for a blood test. So from a kidney perspective, the other thing is that as soon as a patient presents with kidney dysfunction, they tend to have a kidney biopsy. That's what kidney doctors do. So from my perspective as a kidney doctor, it's very easy to diagnose amyloid. One of the problems that we have in the context, and we've heard a lot about delayed diagnosis today, one of the problems that we have in the context of the heart disease associated with amyloid is that you're not going to find a cardiologist that is going to biopsy every case of cardiac amyloidosis, and nor should they. Every case of heart failure. You're not going to biopsy every case you see of heart failure. And so we need these non-invasive ways to diagnose the condition, and we've heard today about echocardiography, cardiac MRI, DPD scintigraphy, etc. In AL amyloidosis, DPD scintigraphy is often negative. It's not necessarily negative, but often the DPD scan will be negative. But the echocardiogram and the cardiac MRI, particularly the cardiac MRI, can be a very good way to identify the presence of amyloid in the heart. The condition can also affect the liver, and this is an SAP scan, what we call an SAP scan, which we do at the Amyloidosis Center, and when it affects the liver, it causes a big liver, often very dramatic weight loss, abnormal liver blood tests, and at the end stages it can cause liver failure. The spleen is often involved. That usually doesn't cause any symptoms other than an enlarged spleen, but an enlarged spleen is not usually associated with any particular symptoms. But as I mentioned earlier, pretty much any organ can be involved. And you can get a patient who's got cardiac involvement and neuropathic involvement, nerve involvement, that might look exactly like a patient with T60A or T80A, as we've heard about, who's actually got AL amyloidosis. That is possible. The prognosis in AL amyloidosis is largely determined by the extent and severity of the cardiac involvement. And this is a study that was conducted by the Mayo Clinic in the US many, many years ago now. The prognosis has changed since this time. But essentially, what it shows is that patients who have severe cardiac involvement do badly, and patients who have milder cardiac involvement with lower biomarkers, blood tests, which show the severity of involvement in the heart, do better. So cardiac involvement really, to this day, remains the main determinant of prognosis. I'm not going to go through the symptoms. You heard from Kathy, she gave a lovely talk about managing the symptoms, and I'm not going to go through these two slides, just in terms of the challenge in AL amyloidosis is often the multi-system nature of the disease. So you might get a patient with cardiac involvement who's got bad heart failure, edema, but they've also got severe autonomic neuropathy and low blood pressure, and trying to get rid of the fluid in a patient with a very low blood pressure can be very challenging, rather like it can in T60A associated hereditary ATTR amyloidosis. So the symptom management can be difficult. So let me just turn our attention to treatment. And I think the first thing to say here is that every treatment that's approved for any type of amyloidosis is designed to stop ongoing amyloid formation. Okay? And what I would like to get through to you today is that amyloid is a dynamic process. The body does get rid of amyloid deposits, okay? But it gets rid of amyloid deposits very, very slowly. And so if you don't treat the underlying condition, you're invariably making amyloid more quickly than you're getting rid of it. So overall, amyloid builds up, the organs fail, patients get worse, okay? The aim with treatment is to slow down, ideally stop ongoing amyloid formation, and change that balance between amyloid formation and amyloid clearance in favor of clearance, so that you're actually clearing amyloid more quickly than you're getting rid of it. And in terms of AL amyloidosis, the principle of treatment is to reduce the concentration of the light chains, which are produced from the bone marrow and misfold and form amyloid, as we talked about earlier, with chemotherapy. So you give chemotherapy directed against the bone marrow to reduce those light chains. And these slides, these four scans on the left, just illustrate that this is a dynamic process. I haven't got a pointer, but the scan on the left shows a patient. It's an anterior whole body scan, and it shows a patient with the black bits are the liver and spleen. So this is a liver and spleen that's full of amyloid. The patient was given chemotherapy and achieved a complete response. In other words, we got rid of their light chains completely, or their amyloid-forming light chains completely. And what you see about a year later in the next scan along is a lot less black bits, a lot less amyloid in the liver and in the spleen. Unfortunately, the underlying disease in this patient came back, as it can do, and what you then see is the amyloid building up again. And unfortunately, wasn't treated quickly enough, and the amyloid continued to build up. But the purpose of showing you this is to show you that amyloid is a dynamic process. Amyloid deposits regress, patients get better. Amyloid deposits accumulate, patients get worse. It's not quite as simple as that. If you've got, as you heard from Mary, if you've got very severe neuropathy, getting rid of amyloid is not necessarily going to make the neuropathy better. But on the whole, if you get rid of amyloid, the organs improve. And certainly, this is the panels on the right here are in cardiac amyloidosis. So this is cardiac AL amyloidosis. If you suppress the light chains and achieve what we call a complete response, or what hematologists call a very good partial response, so that's more than 90% knockdown of the amyloid-forming light chain, you can achieve amyloid regression in the heart. And that might be very relevant to ATTR amyloidosis, and I'll talk about that later on. But you can see amyloid regression in the heart, and patients get dramatically better, even when they present with advanced heart failure in this condition. Not always, I'm afraid, but it's achievable. And this really just illustrates the point that the more you knock down the light chains, the better patients do. So at the top, you have patients who achieve a complete response, and their survival is absolutely excellent. And then the next line down, a very good partial response, so more than 90% knockdown of that light chain. And then not so good, the yellow line is more than between 50 and 90, and then the red line is less than 50. So a direct relationship, as you heard from Mary today, in ATTR amyloidosis. The more you knock down TTR, probably the better. Well, that is absolutely proven in AL amyloidosis. The more you knock down the light chain, the better the outcomes in patients. So the goals of therapy are really to achieve a complete response, get rid of those light chains completely, or at least what we call a VGPR, more than 90% knockdown. And if one hasn't achieved that within about 3 cycles of chemotherapy, within about 3 months, we need to be thinking, should we give more chemotherapy? And obviously the other emphasis is on multidisciplinary care. And we've heard a lot about that today. In AL amyloidosis, it's absolutely essential. As we've heard, we need input from nurses, all sorts of healthcare specialists into patients with multi-system disease. And I'll just finish off, or close to finish off, just by highlighting really the incredible advances. We've heard a lot about the advances, and we'll hear more about the advances in ATTR amyloidosis, but it's been absolutely the same in AL amyloidosis. It's taken perhaps a little bit longer. You know, we go back quite a long way here to the 1990s, when we had what we call stem cell transplantation, high-dose melphalan and stem cell transplantation. And that achieved very good knockdown of those light chains, but it was very toxic. And quite a number of patients who had that treatment, unfortunately, didn't survive the treatment itself. Roll on a good few years, and we achieved, with a drug called Velcade, which some of you may be aware of, and some of you may have actually had, we achieved equally good responses, but with far less risk and far less toxicity. And the real game changer in recent times has been this drug daratumumab, and that's been available for the last few years, and that means that patients with AL amyloidosis, about 80% of them achieve either a complete response or at least a very good partial response. So a very high response rate, meaning a higher chance of good outcomes. And this is the data from that seminal trial, if you like, just showing that if you add daratumumab, the panel on the left with the blue, you get a much higher rate of complete responses or very good partial responses, and that translates into better survival of patients. And I would like to contrast these curves compared to the curves that I showed you earlier. The higher the line, the better the outcome. It's much better now than it was all those years ago. It's not perfect. We've got a lot of work to do, but it's just showing you the improvements that are happening in terms of outcomes. And finally, there are a number of investigational drugs, both in ATTR amyloidosis and AL amyloidosis, which are designed to try and remove existing amyloid deposits. So attack the other side of the pathway. I talked about all the approved drugs are trying to stop ongoing amyloid formation, but there are drugs that are being tested to try and remove existing amyloid, okay? In an ideal world, we could accelerate that natural process, which I told you earlier occurs very slowly. And there are 2 drugs that are currently in trials. Now, unfortunately, one of them reported, it hasn't reported formally, but there was a press release literally a few weeks ago, and this drug was unfortunately unsuccessful at achieving removal of amyloid. But KL101 is currently in trial, and there's a lot of hope for antibody therapy to accelerate removal, which would mean potentially that even patients who present later than we all want them to present, or get diagnosed later than we want them to present, might be able to achieve better remission of their amyloid and better quality of life and long-term outcomes. So it's a multi-system disease. The cardiac involvement really determines is the main determinant of prognosis. I hope I've convinced you that amyloid is a dynamic process. Amyloid deposits do go away. They just don't go away quickly enough unless you can stop them from being made, as it were. And the initial aim of chemotherapy in AL amyloidosis is to reduce the light chains as quickly and completely as possible. And there are lots of expanding possibilities. But again, like all of my colleagues before me, the essential thing, particularly with the treatments that we have at the moment, is that we need to diagnose this disease before it's caused terrible organ dysfunction, because reversing it is more difficult than stopping ongoing accumulation. So thank you very, very much for listening, and just want to acknowledge all my colleagues, all the people here. I speak to Mary pretty much every day of my life, and most of the time I don't quite understand what she's saying, but at the same time it's an absolute pleasure. So thank you very much.